Great, welcome back to Healthcare. We're now switching our work to the Vermont Department of Health budget. We have Commissioner Mark Levine with us today, and as a reminder, VDH crosses both our committee and Human Services. So the commissioner just said he's tailored this budget for us, but if you've read through the budget and have questions, for the other side, that's fine, but we're going to try and at least focus in the beginning on what's for this committee. So welcome.
Thank you. I'm Commissioner Mark Levine, Commissioner of Health. I'm accompanied today by my financial director, Anna Swenson.
Hi.
As you just said, I had a similar presentation to Human Services, but they are very familiar with everything we do. I had a lengthier presentation to the Appropriations Committee, who are not as familiar. And if you need any elements of that, we can feed them in without a problem. But I'll stick to what we have. So picture tells 1,000 words is the first slide.
At one point in the state.
Yes. So now we're getting to the pie graph that really says everything. And the little box actually says even more. Let me turn this thing on. Because the current service budget is fully funded, it shows a state dollar increase of 5%. Now, if you know anything about our department, you know that we are heavily, heavily reliant on federal funding. And the federal funding has been rather luxurious in the COVID era. But now we are in the post-pandemic era. And so much of that funding is going away. And if you compare fiscal year 24, where the federal funding was 48.6%, it's now 42.7% of our total budget. Obviously, that's federally augmented a lot by global commitment money as well, which is another 30%. The purview, of course, of state government is the general fund. And the general fund actually increased a tiny bit, mostly as a reflection of the fact that the others decreased. So 10.7% of our budget is general fund. We used to talk not too many years ago in terms of a budget of 150-something million dollars a year, and you can see it's quite a bit larger than that now. Many of the COVID era grants that had to do with our epidemiology and laboratory capacity, our health equity, our emergency preparedness funding is on the way out. It's not abruptly stopped, but over these next couple years, it will be gradually phased out. Doesn't mean those activities disappear because obviously they had funding prior to this. It's just they got more exuberant funding during COVID. So that's sort of the overview. There's a lot of items in the health department's budget development workbook, I believe it's called, or the ups and downs that we're not going to actually burden you with. And many of those things you're probably seeing department by department are the same in terms of salaries and fringe and special allocations.
Tell me what the special fund is.
Yeah. So the special fund is not just one fund, it has how many things in it?
We have upwards of 20 special funds.
20 special funds.
And is that federal funding, general fund, is it a mix?
It's a mix, but it's mostly, fee revenue.
Okay.
And then, other revenue sources.
Okay.
Such as, the food and lodging fund is, license fees for restaurants and lodging establishments. We have a lead fee fund, which is, lead certification for contractors, that sort of thing. So it's a number of different special funds across that department.
Does immunizations fit in there too?
Yep, and the vaccine purchasing program special fund.
Which is a big chunk.
Yeah, okay.
I understand why the state dollars increased, but what was your budget last year compared to 212, and was it up or down?
It's down. It was like 220, 221. in that range, so slightly down. And the general fund last year accounted for 9.4%, this year 10.7%.
Did you have anything in budget adjustment this year? An increase?
Not an, we did have hardly anything financial.
Yeah, there's
Most of it was non-financial.
Yeah, two minor items in budget adjustment. One was a simple transfer, net neutral transfer of funds from the health department to DEVA. We also added an increase, the special fund increase associated with the vaccine purchasing program and the addition of COVID-19 vaccine to them.
Thank you.
So the state dollar increase of 5% is the general fund increase, or
So that's.
is it more?
It's general fund and the state share of global commitment.
Okay, all right, so it's all of those things,
State
and
dollars.
it's up 5% from last
Yeah, about
fiscal
that.
year. Okay.
There's a little lag.
All right, good. So this is the meat of what you need to know in our budget. First of all, this is the Vermont Nursing Scholarship Program, we'll call it. Forgivable Loan Incentive Program. And that's been a long-standing program for the last 3 to 4 years. It's increased slightly every year. I wish I could give you a lot of data on it. The problem is, you know, whether you look at our state or any other state, because all states are doing this now because of the shortage in healthcare personnel, in this case, nursing. These programs do get people applying for them, and we send out plenty of money. The question is that impact real? Do we feel it? The program is a year for a year, so you get a year of a scholarship and you pay back a year. Does that keep people in Vermont on a consistent basis? It's too early in the program's life to really say anything about that, if you will. We can say that the amount of money has dramatically increased over the last couple of years. And some people are getting 1 year, some people are getting more than 1 year. And we'll just have to see if there's any major outcomes. The major outcome that I could predict if we didn't have it at all would be we wouldn't be as competitive with other states because they're all competing in the same way. It doesn't mean, though, that it's going to work necessarily for more than just a year or two in a nurse's career. But we would hope it would, especially a nurse who's already trained in Vermont, had an experience working in Vermont, and then maybe they would be enticed to stay.
And we have had a joint session with House Commerce on this, if you all remember, and we had VSAC in, and we'll probably be doing another session on workforce, so.
And they are the administrators, if you will, of the program. I can tell you that fiscal year 22, there were 83 awardees, which is about $500,000. Fiscal year 23, 150 awardees, $2.5 million. And in this fiscal year, which hasn't ended yet, we're only 8 shy of 150 awardees and $2.285 million. So clearly the uptake is still there. And we'll just sort of see what the results.
Are those new numbers each time, or does the 83 roll into the 150?
It depends on the person.
Yeah.
So not everybody
Yeah.
goes for as many years.
So, Commissioner, is this now base funded, or is it one-time funding that we look at every year?
This was one-time funding, but now it's
Yeah,
base funding.
historically, it's been a mix of one-time and base, but this 3.3 million that's proposed in the governor's.
Is base. Okay, great. Thank you.
Any other questions on the?
If they go to out-of-state college and they come back and commit to 1 or 2 or 4 years, is that, can they attend an out-of-state college and still get this?
Yeah, I'm pretty sure. Yeah, it's all comers. Just like the physician loans, the goal is to incentivize you to come and stay.
Great.
Okay, so as you know, we have 3 appropriations. The one we just did was in the administration and support appropriation. Here's our second appropriation, which is the public health appropriation. And this is for what I would want to be labeled a cool program that has already received, I think, great acclaim, even though it isn't even up and running yet. But the up and running is part of what we're showing you on the slide. Because the legislature has seen this program back a year ago. So bottom line is this takes unused drugs, usually from nursing home or long-term care settings or hospital settings. Occasionally an individual who may have succumbed to cancer but had very expensive cancer treatments that were not used and could be donated to this program. And there's very strict quality control kind of things, making sure things are in tamper-proof packaging, that there's not been any use of the medication prior to it coming into the program. There's a clinical pharmacist who, as part of the examining everything to make sure that it is safe. And basically, this program can provide, whether they're cheap or whether they're expensive, drugs to Vermonters who might have trouble accessing them otherwise. And these obviously lead to a lot of health benefits for those who might not have even used the drugs. There are also obviously the economic benefits I've been alluding to in terms of healthcare costs. And we're not dumping too many things into the environment, which is always a concern with disposal of drugs. So all in all, it seems to be a great program. There's an appropriation of $355,000 plus from Global Commitment Investment. And this is sort of the administration and operation of the program is what you're seeing.
What is the state match for that? It's like
It's
a
58%.
50, okay, 58% federal and then the rest is, I'm not gonna do the math. 40, maybe 42%.
About
Got
$1
it.
million.
Yeah. Well, no, so 355 is the total.
Oh, okay.
So 42% of that is the state.
Gotcha. Okay, I thought it was the other way.
Yep.
All right, gotcha.
It's cheap.
Yeah.
Talks of
I thought
hundreds
this
of
was
thousands of
our
dollars
percentage.
these days.
I thought.
You remember when we passed this out last year, it was like one bill that just everyone loved. So, and I was
Yes.
excited about it. Yeah,
And we'll start to see the effects of that as the year goes on.
great.
Good. Okay.
Excuse me.
And the last thing is going to be in our substance use appropriation. So residential treatments, facilities are always a topic of discussion in many committees here. One thing that the treatment providers have brought to our attention for many, many years is the need for rate increases. And this has now been achieved. Effective January 1st, 38% rate increase. This basically is funded by a reallocation of funding appropriated in fiscal year 24 to enhance and support the residential treatment system to Global Commitment Program dollars. We're in a good place with that right now, although I would not be surprised to hear that that isn't enough. But it certainly puts them on a very different playing field prior to that.
Is this our budget?
So substance use is not technically ours. It does fall under human services, but this is good for us to understand. Yeah.
Right, no, I
Yeah, but
understand.
we won't be making a recommendation on this.
Dr. Levine, when you say 38% rate increase.
Yep.
Rate increase for what? What do we, I don't,
For the charges that a day in a facility
Okay,
takes.
a day in the facility.
So there's several levels of care,
Yeah,
and each of them, there's an intensive level and a less intensive level, but they all cost money.
yeah. And it's been too low for a long time if there's a rate increase. Right?
Yeah, I would agree with that.
It's very similar to what we discuss in here with our providers for Medicaid.
Yeah.
Yeah,
I have to say, though, we have really tried to be bringing this sector of healthcare into a new place in terms of what's commonly called value-based care, and making sure that there's an accountability to be able to make sure that the quality and everything else is commensurate with what an increase would bring.
I'm not quite sure I understand. So you were able to give a 38% rate increase. And was it originally allocated all state dollars, but now you're using global commitment dollars? Is that how you were able to achieve that? What's the reallocation?
Sure, so it was appropriated in FY 24 as a mix of general fund and global commitment investment.
Okay,
And by transitioning it to global commitment program, we're able to figure out my
Okay.
cut in terms of
Got it.
dollars.
There's always been the global commitment
Yeah.
component.
So we're saving state dollars doing it this way.
We're allowing for we're spending the same amount of state dollars, but it allows a larger increase in rate.
Thank you.
Because then you get the match on.
okay.
This, I can either save you time and not do the slide, or I can go through the slide. It's,
It would be helpful.
yeah, it's something we developed because the substance use system of care is rather complex.
Yeah.
Hopefully people can see things. It goes from highest intensity down to lowest intensity, if you will. And we just talked about the residential, which is often called inpatient treatment system. That's at the top. And there are two types of beds, level 3 and level 3.5 or 3.7 and level 3.1. The former is the higher intensity, the latter is the lower intensity. This is not to give one the impression that everyone who seeks treatment for substance use needs an inpatient facility. Probably we could build a slide even higher and have the hospital on top, because people who have major complications of substance use that are causing medical issues would be there. The majority of people in Vermont, knowing that these are less than 150 beds total, the majority of people in Vermont are in the hub and spoke system, that everybody knows those terms. That's really an outpatient-based system. Hubs are these complex patient substance use provider, sort of addiction specialist run settings, distributed through the state, with more coming. And those are predominantly for people who are requiring methadone, because that can only be prescribed by an addiction specialist. But there are also people there who are not on methadone, who may be getting buprenorphine, as opposed to the spokes, which are, think of them as practices, primary care and other, where providers may be able to provide monthly prescriptions for buprenorphine. They cannot prescribe methadone at those. These systems are sort of bundled so that though some people may only want the medication for opioid use disorder, they have case management, they have counseling, everything else built into it as part of the Blueprint system of care. And then the next level we call outpatient, intensive outpatient. So if you're not going to a traditional hub or spoke, you may be going to one of our preferred providers, or through private insurance, you may be going to any provider who can provide you the licensed provider counseling, if you will, for which there's a whole system. or intensive outpatient, which means more hours per week in the outpatient setting than you would get in a traditional spoke or traditional outpatient setting. So we've got all kinds of numbers of clients that are on these slides, but the hub and spoke system, think about as 12,000 plus Vermonters. The intensive outpatient, a couple hundred. The adult outpatient, 4,200. The psychology type settings, 3,600 licensed professionals with whatever patients would attend them. So those three levels is the treatment system. The next level is really, we call intervention harm reduction, which is really trying to manage people and keep them alive, knowing they are potentially, with the fentanyl crisis and the toxicity of the drug supply, able to die at any time, really. So a whole system of syringe service programs would provide a trusted community for people, not only to exchange their needles and syringes, but to be connected to treatment, to be connected to any kind of services they need, whether it's wound management or other. There's drug courts, the impaired driver program, public inebriate programs, generally more for alcohol than for opioid management, and withdrawal management. So those are more acute levels, and they are really prior to people saying, I am ready for treatment. It's in that period of time where they're still not quite at the point in their process where they just say, I'm done with this, I want to be treated. And they're in kind of a very tenuous situation where they need to make sure that, and we need to make sure we do everything to keep them alive so they can make it. The next level is purely recovery. So recovery doesn't mean it's been 10 years and I never touched a drug again. It can mean I entered treatment today and that's the first day of recovery. But either way, we have recovery centers in every district of the state. We have a modest amount of what's called recovery housing for people who are trying to get back on their feet again, need a roof over their head, want to look for a job and participate in their treatment still. And they may be met by recovery coaches who are now in every hospital. So if you're brought in with an overdose and you've been resuscitated, there'll be not only the medical team to meet you, but there'll be a recovery coach that you can talk with, someone who you might trust more because they have lived experience and can just sort of help guide you through the system. And if you're not ready, they're at least a connection that you have for when you are ready. And then the bottom of the slide, I don't want to de-emphasize it, but it's very prevention oriented. And as you know, the legislature has several years ago provided $3 million per year for prevention to augment what we get from the federal government. And much of that $3 million is now coming through the cannabis pathway, which is what it was meant to do as that pathway matures and can provide the amount of money that's needed. But this involves all kinds of school-based programs, so-called community coalitions, where there's a community-wide effort to reduce particularly uptake of substances in our youth and adolescents. And the Vermont Help Link program, which is a web-based and phone-based system where you can get help anywhere in this system of care with one connection.
Great. I think we had a couple of questions, Art, and then Leslie.
Yes, I wondered, I have a couple questions here. The syringe service program and the recovery coach program, Doctor, you mentioned that, people come in and change needles, syringes, whatever
Yes.
that is. When they do that, is there a requirement that they try to get off the drug? Is there something with?
No.
So you just change the stuff up?
Exactly. The goal is that you keep returning because you trust everyone who works there,
Okay,
and they are your kind of community.
yeah,
And when you are ready, they are like, we will take you by the hand and here's your first dose. Several of them can actually initiate treatment on site. Others are connected to a treatment provider who they literally walk the person over there.
and the same thing with the recovery coach.
Yeah, the recovery coach is really, they're at the recovery centers. They're on call 24/7, so they'll go to an emergency room when the
Okay,
call
but
comes
if
in.
somebody
And there's
overdosed,
no commitment.
No
It's
commitment to
Just a
proceed
relation,
with.
it's a relationship building.
okay, so if someone comes in, overdoses, they resuscitate, he says, no, I'm fine, I'm out of here. They could just leave.
They
and
can
no-
just
nothing.
leave. They don't have
Okay.
to see anyone, or they can agree to see someone, but not.
Okay. And my other question is, and I attended one of these on Friday, is there any faith-based recovery things that you considered, you know of them? Are
Oh,
you
yeah.
categorizing them anywhere here?
They're not categorized here because we don't administer them through the state,
Right,
but they do exist in the state and out of state. Our policy or our philosophy, I guess I would call it, is any pathway to recovery works for us if it works for the person. However, I would dare say that the evidence base behind the faith-based strategy is not as robust as the evidence base behind the medication-based strategy. But I would never tell someone, you can't go there,
Yeah,
that's,
sure.
that's gonna
Okay.
hurt you.
Yeah.
Because if that's the way they perceive is gonna help them, God, they should try.
yeah,
Because, people who use medications doesn't mean they start a buprenorphine today and smooth sailing the rest of their life. They may have relapses, it's a chronic condition.
Yeah.
So
Yeah.
whatever works.
okay, thank you.
Leslie?
Thank you very much. This is really helpful to see the structure. I'm curious about the school-based health. There's sort of, it's like, you look like you reach 9,000 students or something. We know we have 80,000. So do you have aspiration to go broader?
Yes,
How
and
well-
and when I show you this opioid settlement money slide,
Great.
you'll see one of those aspirations coming real.
Great.
Thank you. I was curious, you mentioned about the Medicaid increase for the residential treatment, and you're speaking about the
Yes.
prevention and early intervention. Was there funding that was increased at all, or what does that look like for those lower tiers in this budget? This is my first budget cycle, so I'm trying
So-
to find the pieces.
And what you've seen in this budget, nothing, but what you'll see on the opioid settlement slide, plenty.
Okay, great. Thank you.
Yeah.
All right,
And I also wanted to just elaborate on one other thing that just forgot.
Sorry. We do it all the
I'll
time.
come back to it.
You can throw my sticky notes in
Yeah.
there. Daisy?
There's so much I could tell you.
Daisy?
I just want to call out that I see MSWs and psychologists
Yeah, yeah.
there. I also recognize, many of us probably recognize this diagram and some of the symbols from the Department of Mental Health. So I appreciate the perceived effort toward integration. And I wonder if you could speak a little bit to other places that mental health professionals show up in the system, hopefully at other levels,
Yeah.
not just the outpatient.
Remind me of what I was going to talk about. Because one thing you heard in the last session was an effort to have our hubs become more than they are right now. Right now, they are opioid treatment centers. And you have to have an opioid use disorder to go there, but it doesn't mean you shouldn't have other things managed there, perhaps. So broadening the hub system to allow co-occurring diagnoses, mental health and substance use, to allow co-occurring substances, alcohol and opioids, or whatever other substance the person is using, is a major part of things. And also last session, and you heard, I think, a progress report from Dr. Saroyan just recently about the spoke system and the blueprint plan for further integration and allowing more co-occurring work to occur. Not only screening at the level of someone coming in a pediatric or adult practice, but actually making sure that the system can manage co-occurring substance use disorders, co-occurring mental health and substance use disorder. So that's been a big focus of what we're trying to do.
We have not yet heard from Dr. Soren, but he's on our agenda in March.
Okay, perfect.
I think he was in the Senate.
That's what you'll hear.
And is that happening anywhere, or it's not? I
Yeah,
don't
so,
see it happening anywhere in the prevention, early intervention.
well, except in recovery coaches, I mean, there's so many connections that the recovery centers are trying to make for people. You know, the recovery centers themselves have things like, you know, yoga and activities that will help someone with mindfulness, et cetera. But then they are a referral hub, whether it's referral to employment opportunities, referral to housing opportunities, referral to other medical and psychological needs. So that all kind of is built into the system of care that they've developed. Everything else, you know, the spoke system is basically based on integrating substance use into the rest of primary care and other care, OP care, you name it.
Right, it's just
So-
such a big piece of prevention too.
Oh, absolutely. You know, you know about the Mental Health Integration Council report we put out also, which really does a lot to focus people on sort of a whole model, focuses on the DAs and what the CHCDC model could, I think I said that right.
ADHD.
CHC, thank you.
CC. CCA.
Certified Behavioral Health Centers.
Yeah.
Yes.
ADHD.
What they can look like in terms of a much more integrated approach as well. And it's sort of exactly what we do with the hubs. You know, so if you have a physical issue, perhaps you test hepatitis C because of your injection drug use. Why can't you be diagnosed and treated at the hub where you're going every day anyways? If you have a mental health issue, and you want to keep a job, and keeping your job is already hard to do because you have to travel to the hub and back every day. Maybe it'd be nice if you could get one site care for all of your problems. So that's sort of our thought process.
Great. Thank you.
Okay, we'll move on to the next slide. So this is more of a repeat of what I said about the $3 million, based on the legislative intent from 2022. And this converts things now to a full $3 million base for fiscal year 25.
Okay. Perfect. So let me just make sure I understand. So that means every year there's going to be $3 million in there? Is that
Yes.
Yeah, for ongoing. From the.
A minimum of $3 million.
Okay.
Because when the cannabis success rate, I'll call it, gets even better and better, you know, there'll be more coming to prevention. But
So
3
that-
million is the floor.
And that's coming from the cannabis revenue.
Yes.
Yes.
Thank you.
So the last two slides are the opioid settlement advisory committee. So this first one is just a review. And so I don't know if you need the review. It's just all the things that happened the last time around. We gave a full update to the House Human Services Committee on where each of these are. And we have a link on our website, which shows you a spreadsheet to actually let you view where each of these things is. But they're all up and running, so to speak. And the one that is lagging behind the most is the treatment satellite services, which are these, I call them hublets, which are in the vicinity of a hub that's already up and running, but geographically located in a place where people have to travel too long. So think, this has nothing to do with Bennington, which is the one that is in the news a lot. Bennington is prior to this. Think about if you live in Addison County, there's Rutland and there's Burlington. So one of these located in Addison County would really take a big chunk of the population. Same thing on the eastern side of the state, thinking between Brattleboro and points north. So Those are taking more time in terms of the RFP process and getting treatment providers lined up because they have to actually either build or upgrade a building that will become a full-service pharmacy for a controlled substance, mainly methadone. So that's a little behind. Naloxone expansion, case management, syringe service program work, contingency management for stimulant use disorder, telehealth wound care, fentanyl and test strips, all up and running. Drug testing device grants are now going out, but you won't see these devices in operation yet. So they're still work in progress.
Okay.
And then the last slide, oh, sorry.
Could you explain what telehealth wound care
Yes,
has to do with the drug treatment?
absolutely. So it has to do with xylazine, which is an anesthetic agent that's used in the veterinary setting. However, when fentanyl comes in across the Mexican border or from China, it's now frequently, but not always, mixed with xylazine. Not even a narcotic, an anesthetic agent, which people who use fentanyl and other opioids feel that it prolongs the euphoria they might get, might require less injections per day, because since people transition from heroin to fentanyl, it requires more injections a day because it's a shorter acting drug for them to feel comfortable. So xylazine's mixed in. Xylazine, unfortunately, doesn't respond to Narcan, but we tell people still use Narcan because there's almost always fentanyl that will be reversed. But xylazine can provide more sedation if it's been taken in a large quantity. It also has this curious side effect of either at the site of injection or commonly now away from sites of injection, wounds developing, which have this very black scar on them, scab on them, are quite ugly, can get infected and cause other problems. So these are active wounds that need to be managed by people who aren't necessarily trusting of or frequenting the healthcare setting. So if they can be identified, like when they go to a syringe service program, for instance, this program allows a connection through a telehealth appointment with one of the infectious disease people at UVM to actually conduct the appointment and help manage the wound. And if antibiotics are needed, provide those, et cetera. So it's really, it's another pathway for us to capture a population that might not be enthusiastic about connecting with it. And it could be a potential pathway to their success.
Leslie and Maureen?
Thank you. Is this last slide?
No, the last slide is the new recommendations of the settlement.
That's, oh, okay, the 25. Okay, I'll wait till you get to that. But I will ask, you mentioned the Integration Council report.
Yeah.
Thank you. That was great. And I noticed we had testimony on the Vermont Child Psychiatry Access Program, and it was
Love it.
really cool.
Love it.
Yeah. Do you see another role for that kind of model in primary care other than psychiatry?
Well, before I get to that, I had a special sentence inserted in the report because the CPAP program begins with C, which is child.
Yes.
Well, believe me, adults have a lot of trouble getting into mental health care settings too. So the goal of the report was to say, build on the success of that and
Great.
replicate it in the adult setting.
Great.
So that's one answer to your question.
Yeah.
But you wanted,
Are there other arenas that might help I'm just thinking about helping primary care.
yeah.
Difficult diagnoses and management.
Yeah, so we already have one in Alzheimer's disease and related dementias.
Mhm.
We've built a hub and spoke model to support primary care practitioners in the accurate diagnosis of Alzheimer's and then in the elements that are more challenging like treatment and caregiver support. So that's one place. There's a program called ECHO that you probably all are aware of, which is a national thing, but it's basically on computer, doesn't have to be in person. It's an interactive program for addressing whatever medical issue you think is important to address. So the one that it was built on was hepatitis C,
Mm.
because frankly, hepatitis C treatment doesn't have to be with a liver specialist. It can be with a primary care physician, and all they need is to be well-trained in that arena.
Mhm.
So that's where it had its initial success. In Vermont, we've also done it with narcotic prescribing. We've done it with substance use treatment. So the answer to your question is, there's a million ways
Spreading,
you
yeah.
can do, and we need to keep building on prior successes and models like CPAP, like ECHO, to continue that success.
And
The other success is that sort of, it has a fancier name than I'm going to give it, but you have an academic person come to your office to do what's called academic detailing.
Oh.
Just like a drug rep would come to a doctor's office and try to make sure they use only their drug for whatever condition. We have a program where topic-based, the university comes to the practice
Very cool.
and helps build skills.
So how's the uptake on these programs? Are people,
The uptake's great.
cool?
Yeah, people love these.
Great.
You have to pace them because there's
Well,
only so much time in practice to do these things.
thank you. That's great work.
Ari?
Mine's for after the last slide.
Okay, so hold, because we have a couple, I know we have a couple for after Art. Did you have something?
Yeah, this slide shows what we did this year.
Yes,
And the next one shows what we're going to do. So we'll
Yes.
stick with this one. So the one-time opioid abatement special fund happens every year
yes, it is an ongoing fund
It's
for
an on-
18 years,
for
probably.
18 years.
Mhm.
And our amount comes from what? What drives the?
So this is opioid settlements that our Attorney General's office has entered into, often, almost always with other states. So it's the pharmaceutical companies, it's pharmaceutical distributing companies, and most recently, the one in the news was actually sort of a public advertising firm or whatever that further help people get addicted to drugs.
So none of this is state dollars.
None of it is state dollars. It's
Okay,
all
right,
coming in
right.
through court
do want-
settlements.
Okay.
And it's unpredictable. Some, we get several $1 million a year for 18 years,
Right.
which could be $54 million. Others, we get one-time payment. Others, it gets staggered. We thought we would have more money this year than we did, but monies that we thought were coming in the last quarter of 24 still haven't come in the first quarter of 25. So we couldn't spend that money, so we didn't.
So the court settlement's based on the fact that people prescribed medicine, people got hooked on it.
Yes,
And
yes,
okay.
exactly. And,
That's exactly what I wanted to know.
and the pharmaceutical companies enabled that to happen.
Enabled it to happen. Thanks. That's all.
So we have a couple of non-related questions to this. So if you can talk a little bit on number 7 on the student assistance piece. I'm sorry, I'm on the next slide.
Oh, you're on the next slide.
Yeah, go to the next slide.
So,
If you can just do number 7, and then I want to move off to some of the other questions we have.
good, okay. I'll just point out that it was 8.2 million last year, and you'll see it's less than 5 this year. Doesn't mean by the time the Appropriations Committee makes its decisions, there won't be more money in the pot, but there isn't now. So number 7 is the principle of we should also treat prevention. Most of the first year's work is exclusively on harm reduction, keeping people alive at a time when opioid overdose deaths continue to grow. Or they're on getting better access to the treatment system. Those are the two unifying themes. This year, we certainly didn't want to abandon those themes, and we have supported those themes. However, when you come down to how the committee ranked things from a priority level, primary prevention in this form that's in number 7 ranked high. Now, when I say primary prevention, we're talking about not letting our youth become heroin users. It's really not letting our youth become nicotine users, alcohol users, cannabis users, etc. All of the things that prime the brain for eventual opioid use disorder. So we were talking about the school-based programs and the fact that we have federal money to help us fund a lot of what goes on in prevention, but insufficient to be geographically equitable throughout the entire state.
Yeah.
The programs themselves, we know are successful. We just need to have a broader scalability. So this almost $1.5 billion allows us to expand the school-based component of this further. And when I say the school-based component, it means school curriculum, it means student assistance professionals, SAPs, who can only cover so many schools at one time, depending on how large a school, one school at one time, but do become very trusted confidants within the building, so to speak, both for students and for faculty and administrators, and can provide a lot of the not only individual work, but the more global work that goes on in the schools. The 3 million that we were talking about from the Cannabis Fund and the State General Fund is really working on these prevention coalitions around the state, which are very successful at working along the Iceland model, where it's a sort of youth have a voice. The community feels like they can contribute to helping the upbringing of all of their youth, after school activities, all of that kind of stuff that happens sort of out of view, building those in a much bigger, robust way. And so the 3 million has gone a long way to helping us make that way more geographically equitable across the state.
It's great news. Topper?
Is it just limited to elementary and secondary schools? Or
Like colleges, until you mean, no, it's not colleges. Just everything but higher education. Yeah.
That's like,
Those have a lot of resources going into them anyways. I mean, they are very dedicated to this kind of work, but it's not from state money.
I was just wondering, thank you.
Yeah.
That's very cool. How do you said these were very successful. I'm just wondering how you measure success.
Yeah.
If that,
Oh, yeah. We've got some great slides we could share with you. There's two angles. One is just looking over 2 decades when these prevention coalitions have been in place in a certain region of the state, looking at our youth risk behavior survey and young adult surveys of all kinds of questions, but focus on the substance questions, which really focus on tobacco, vaping, alcohol, and cannabis predominantly, and looking at the rates of what youth tell us they're doing or not doing. And you see these dramatic drop-offs.
in those arenas that year in
Yes.
sections of the state.
And then the second way we look at it is, unfortunately, funding is not always steady. So we have a 20-year view of the region, when the funding was turned on, when the funding wasn't available. And you see actually a correlation with improvement in rates versus an increase in rates versus an improvement in rates based on when they had the funding.
Thank you.
I want to do one more question on this, and then we have to get to another couple other questions. Go ahead, Melanie.
Just really excited to see the expansion of the SAP programs as a former teacher. It's just really exciting. And I was just curious, how do schools access this? And then the question of rural equity and how is it distributed? Just curious the mechanism for that. So
It's how are we choosing communities? You know, that's a great question. Because we already know who has and who doesn't have. I'm gonna have to ask my
Great.
DSU people. Because I know we have I don't think it's just an RFP kind of thing, because we kind of know who's in need and who's not. Well, they've got action.
Thanks so much. This was very helpful. Thank you. We do have a couple other questions. I'm going to start. I don't see anything in the budget, so correct me if I'm wrong, for another household survey that would be due, I think, this year. This would be the 3rd year.
Yeah. And I know that's kind of built in. Are you aware, Anna, of It's already,
Follow up on that.
yeah.
Okay, that would be very helpful. And are there any ARPA funds that you all had that are not yet spent? No.
The answer is no to that.
Okay. Okay. Alyssa?
So not budget related, but since you're here and you're rarely over here, so we passed Act 45, which had a provision around safe storage of firearms. And I'm wondering, what is the Department of Health? I believe that kind of falls under your purview.
Yes, under
What
our,
are you doing around educating the public about it? Do you have any programs? Are there anything in the works for trying to get that information out there?
yeah, so safe storage is a big part of our injury prevention, substance use, firearm work. It's in our DEPREP 6 section for emergency preparedness. And when the law was crafted in terms of the wording, it wasn't like you had to do it, but if something happened and you were discovered to have not done that, there would be penalties, I believe. By framing it sort of the way it sounds. I'm a doctor, I try to be precise, but in the legal world, I can be a little general. So excuse me for that. So we have a whole part of our website dedicated to safe storage. My understanding is at the time of purchase, you can receive a gun lock at the time. And that's the best public health way to do it, because then it's sort of like you don't have to consciously do something. It sort of can happen at the same time. But we can't like make people use them or create the situation in their home where it would be the safest. So there it's really education. And so we did a bunch of the education around the time the law came into effect, but we also did the education constantly through our web-based stuff.
Would the Department of Health be open to possibly creating educational material that could be handed out to a wider
Yeah.
audience?
I won't commit to it because I'm thinking we probably have it already, but I'll get back to you to
Okay.
make sure.
Great, thanks.
Laura, you had
That's a great idea.
question?
Yeah, thank you for being here. It's notable that there's no mention of COVID, which I think is partly in relation to,
Are you happy about that? Yeah.
yes, and curious. We did
I'll tell you about
still have a spike, an increase in hospitalizations as expected over the fall. I think January looks like the peak.
Yeah.
We're at low levels throughout the state as far as from what information we can gather, except for the southern part of the state. Is there still funding for the Department of Health to help people with testing, vaccines, masks? Where can you give us a status update?
So COVID is now, our approach now, as opposed to COVID is respiratory virus season. It's really RSV, COVID, and flu, because so much is similar in the approach. But we still have a dedicated part of our epidemiology section, specifically COVID. It's just not the whole department anymore. It was all hands on deck for a couple of years. Now, COVID is a slice, just like vector-borne diseases is a slice, GI diseases is a slice, COVID is a slice. So, much of our messaging is now, this is respiratory virus season. The two things you can do are get a flu shot and a COVID shot. Here's why you should do that. Here's how you can do that. Here's who should do it, which essentially is everybody. And then there's also RSV, which is a little more special because if you want to get a shot for that, you have to be 60 or older and, at least think about who you are. Or you have to be newborn or a mother of, or not a mother, but a pregnant person who will have a child at the right time so that they could get the shot during the pregnancy. So little angles on that. Well, the mask guidance and other types of, how to keep yourself safe, all that is all over our website. And it's dictated by that level that you called low, which hasn't changed from low in forever right now. So we don't actually talk about it anymore because at low, it's not required that anything happen. It's personal choice really about the protective mechanisms you want to take. It's only when it gets up to a higher level. And we don't appear to be going there at this point with COVID.
So that there's no longer, there's a budget down compared to previous years as far as the state providing masks,
Yeah, so right now,
immunization program, and so that's a budget down.
that's a budget down, yes. We used to have places to get vaccines that the state administered, mass vaccination sites. That doesn't happen anymore. But again, we're very closely tied in with the whole system of care and making sure that people who are more vulnerable or people who have traditionally had less access to things have access.
Do providers report to the Department of Health, patient like COVID? If my provider knows I had COVID, does that information get to you, or do we as individuals have to go to the website?
Individuals usually have to go and report it, unless there's a laboratory report of a PCR test, which we will get. But most people, of course, are not doing PCR tests. They're doing home antigen tests. So that's why we don't use cases anymore to find where we are. We use hospitalizations.
Thank you.
Art,
Yeah, back to the opioid thing, doctor. Are providers still prescribing these very addictive drugs? They are.
Yeah. But,
Why?
well, because they do have a role in healthcare still. If you're a post-operative patient, if you just had a fracture, et cetera. We don't yet have the magic drugs that aren't addicting, but that are stronger than Advil or Tylenol that can help people. So we still prescribe them. However, one of the successes of the last 10 years is our Vermont prescription monitoring system. We have data, which is very easy to show you, where the rate of prescribing has just plummeted. So
I hope so.
So-
I mean, we're creating our own problem here, see? But-
No, right, no,
This isn't the place.
No, this is the place. So the bottom line is, clinicians are way smarter about the way they prescribe these now. Many won't prescribe them at all, which actually can be problematic for some people. But they certainly know how to prescribe in the way it should be prescribed for acute pain, so that people don't become chronically dependent on the drugs. So
I know
that's.
people in
that-
my family have refused to use them.
Yeah, no, and I think that's fine.
Because of.
Right, and that's a success story.
Yeah.
It really is. So we've seen a dramatic change. The other dramatic change
So
is
we
that-
should see at the other end.
Well, no, that's the problem, because the dramatic change I'm about to describe is most people who have an opioid use disorder now didn't get it by prescription drugs.
Okay.
They got it because they started injecting fentanyl. It's amazing how that transition has been made.
So, all right, if all things are equal, that would have come way down.
Yes, yes,
All right, thank you.
yeah. And when you look at overdose,
Great to know.
and when you look at our overdose death data, the percentage that have a prescription opioid in their system at the time of death has gone way, way down. The percentage that have fentanyl is 94%. So,
I think we have to be careful too about swinging the other way so that people are undertreated for pain.
well, that's always been the concern,
that's
people
where it
feel.
started. We were badgered that we were undertreated.
That's right.
That's all of it.
Right, the smiley face system.
Yeah,
How much
that was
pain.
not good.
So now we're in a good place now, but there are some who still feel abandoned by their physician because they can't get someone to keep prescribing and they've been stable on their drug and not abusing it, et cetera. So it's a challenge for the system.
Thank you. It's always a pleasure.
Okay.
And If we, as we dig in, Daisy and Melanie are our budget liaisons. As we dig in, if we have more questions, they reach out to you?
Oh, yeah.
Great, thank you.
And we'll send what we told you.